Okay, so just a reminder to people, we are being recorded again. Okay, it's 2:10, so we're going to make a fresh start. So far, we've looked at some of the research that indicates that people are misusing the assumption of capacity. And what I'm saying, in order to guard against that, in every case, anytime a person's referred to services, there should be some kind of record of their ability to be able to make the key decisions. Just a basic case note can be a chunky paragraph. And at that point, when we're considering capacity, if there's a reason to doubt capacity, we would go on and we would do the full capacity assessment, with the starting point being the assumption of capacity. And I'm saying that what the assumption of capacity means is when we're doing a capacity assessment, then it's for the assessor to make a determination. It's not for the person to prove that they have capacity. The person has capacity until it's possible for the assessor to record in writing what it is that's led to their conclusion that the person lacks capacity. I'm saying if the person's really, we're not sure in terms of whether they've got capacity or not, then we go with the assumption of capacity. So I just want to sort of just, again, before we start, has anybody got any questions, anything they want to clarify before we move on? Okay, so I'm going to push you on this. Let's go back to Kanya. Let's say in Kanya's case, we really can't reach a conclusion. We can't disprove the assumption of capacity. We've been to see her several times. We're really not sure whether she's got capacity or not. Maybe we've got colleagues, specialist colleagues to come along and they're not sure. And the doctors and nurses aren't sure. But she wants to go home, but the risks of going home are grave. We're seriously concerned that if she goes home now, she's going to refuse services and she's going to suffer grave self-neglect and she could be dead in a short space of time. And we're really not sure whether she's got capacity. What options are available to us? What can we do? We're saying we can't, at this moment in time, we can't disprove. So Sally's saying continue the assessments at home. Let's say she's going to bolt the door, not let people in. What options are there? Risk assessment. Risk assessment, Sadia says that the risks are grave and she's a very high chance she's going to neglect herself and may die within a short space of time. Which if she has capacity, then she can make that decision. Yeah, she's able to make a decision that other people may think is unwise. If she can understand, retain and weigh. But we're really not sure. We really can't work out. What options are there? Safeguarding, yeah, we could do a safeguarding. Safeguarding doesn't really give us any powers. So the statutory power in terms of safeguarding, section 42 of the Care Act, that says we've got a duty to assess, but the powers to intervene in terms of safeguarding come from the Mental Capacity Act, Mental Health Act, things like inherent jurisdiction. So we can do a safeguarding, we might be in exactly the same situation. What can we do? The risks are grave, she's right on the borderline of potentially having capacity, but we're concerned that if she goes home, she's going to suffer greatly and possibly die. Are there any other options? Okay, let's rephrase the question. Is there anywhere we can go? If there's concerns about, yeah, we can ask for mental health input. Mental health will probably say, does she have a treatable mental health condition? Tricia, you've put Court protection. Janine's put court protection. Do you want to say a bit more? Does anyone want to come in there?
I think you would want to explore the options. Is it in terms of a relevant place or appropriate place? And if she doesn't have that, I suppose, legal safeguards to make the decision, I think you would want for that decision to be heard. And in relation to, I suppose, the fluctuating capacity or the discrepancies around the actual decision-making process, I think it would probably allow them to make that decision and make that ruling.
Yeah. Yeah, spot on. So yeah, the third stage in this mental capacity triage, let's say we do a capacity assessment. We're really not sure whether the person's got capacity. The risks are sky high. This is a situation where you would refer on. So this is where you get external support. So yeah, you get your specialist expertise and they might come along and say, we're not sure. So this would be the case where you're having a conversation with legal about whether there's sufficient grounds to go to court protection, to get a judge to make the final determination on whether the person's got capacity. Anybody, again, we'll play higher and lower. Anybody know how much High Court judges get paid per annum? Anyone want to shout a figure out to us? You don't have to put your hand up for this, just shout it out. What's the average salary of a High Court judge per year?
200,000.
So 70,000? Oh, far higher.
200,000.
Someone, Emily, you said something?
200,000.
Slightly more. It's recently, a recent pay award body. It's over between 200 and 230,000 pound a year. That's what the average High Court judge is. This is way above your pay grade. So when we're trying to make a decision about when someone has, if we're not sure whether someone has capacity in terms of making a decision that potentially is going to put their own life at risk, High Court judges get paid lots and lots of money to make these life and death decisions. And what they would do, they would hear things before courts, they would hear all different parties, they would hear family, they would probably instruct an expert doctor or psychologist to do an independent capacity assessment. But at the end of the day, these are the kind of situations where they would make the final call. So yeah, the mental capacity triage, in every case in referral to social care, we consider capacity. We document a case note or a paragraph in the care record, just about their ability to make key decisions. If there's a reason to doubt capacity, we go on and do a formal capacity assessment, with the starting point being the assumption of capacity. Is it possible to disprove the assumption of capacity? And if we do that, and we're not sure, we can't reach a conclusion, and the risks are high, then at that point we may need to consider going to court, or at least having a conversation with legal services. Sadia, you've got your hand up.
Yes, I mean, most of the time we do need the decisions made soon because the person needs to be discharged from the hospital. The person herself is really desperate to be out of the hospital or I mean, from home. There's a, I mean, tricky situation at home and they need to move into a care home. We need that, decision made soon. And we have already delayed it after, I mean, doing joint visits, getting other professionals involved. So we have already, I mean, taken a lot of time. And then with the court procedures, is it, I mean, is it realistic, practical? I understand where, I mean, it needs to be done. This is the process that you are discussing, but in real life scenarios, it's going to be quite difficult, isn't it? Waiting on the decision, especially when the court is to be involved.
It can be. It's easy for me to sit here and say and do this. So we're talking about the extreme situations here where, yeah, if the person's clearly lacking capacity or clearly has capacity, then it's a lot easier in terms of action, in terms of what to do. If we're not sure, and the risks are grave, then yeah, it needs to go to court. In emergencies, it's called a without notice application. And there's all sorts of situations. In the same way there's always a duty social worker or a duty doctor, there's always a duty High Court judge. And there's all sorts of situations where they've got the High Court judge, the duty judge, out of bed at 3 o'clock in the morning, and they've made these interim decisions, life and death decisions, over the phone at 3 o'clock in the morning. So I'm not saying that at the moment she's in a safe place. So it may take longer than that. But an expectation, I think, in this case, because her right to liberty and her human rights are so important, and her autonomy, the court, if you're not sure in terms of these decisions, and the risks are grave of her going back home and neglecting herself to the point of death, I think there would be an expectation you at least have a conversation with your legal service about this. And I say if the risks are so grave that it requires an emergency application, it can be heard within a few hours. I can send out, with the handouts for this, there's a guidance notes by Essex Street Chambers for social workers and other professionals about the making of without notice applications. So I'll try and send that on via Janine after this meeting. I'm not sure, some of you are probably aware of this. I'm going to tread tentatively here. This was a Salford case, Salford Safeguarding Board. The case of Eric, where things went badly wrong. This was, I think, 2020. This was published. So Eric, I think it's a pseudonym, I don't think it's his real name, was a man in his 80s. He had a history of depression and anxiety in the past, and generally lived a full and active life, lived with his wife, and I think daughter was involved in providing support for him. And he developed quite severe gastric problems. And as a result, he was quite disabled by those gastric problems. And it got to the point where he started refusing to eat and drink. Took to his bed, and the GP was involved. And the GP went and saw him and said, appears to have capacity, making an unwise choice to refuse support. Eventually, District Nursing Service got involved. And yeah, he was refusing support from district nurses. By this time, he wasn't eating, drinking. He was incontinent at times and staying in bed. And District Nursing Service said, appears to have capacity, making an unwise choice. And this was repeated. This was several GP appointments, several District Nursing Service appointments. Got referred to mental health services. Mental health services said, no, this is physical health, you deal with it. I think got referred to the local authority. Again, local authority said, appears to have capacity, was bounced around. Nobody actually recorded in terms of their rationale as to why they felt he had capacity. What was recorded, appears to have capacity, making an unwise choice. There was some consideration of safeguarding, but by that time, there was a feeling that possibly he might lack capacity. And there was consideration about whether it needs to go to court to get a judge to determine his capacity, but the application was never made. Eventually, I think in October 2020 or 19, he was admitted to Salford Royal Hospital and died. And I think the coroner ruled the cause of death was starvation. And yeah, the coroner was basically saying that it's a very strong indication that at points in this timeline, Eric had lacked capacity to make decisions about his care and treatment. And I think the Safeguard Adult Review said that the main learning point from this was the massive over-reliance on the assumption of capacity by practitioners from all different disciplines, GP, local authority, district nurses, mental health team, all of them said appears to have capacity, able to make an unwise decision, but nobody had recorded in terms of how they came to that conclusion. And at times, looking at the case record, there were times when people were going around to his house, he was lying in bed, smelling of feces at times, with the covers over his head and swearing at people, or refusing to speak to people, but appears to have capacity. So yeah, pretty tragic example of where things go wrong. This is available, I think, on Salford Safeguarding Adults Board website. So yeah, this is in the public sphere if people want to read it. But please, please, please don't ever say person appears to have capacity without good record. Emma, you've got your hand up.
Yeah, I thought I was on mute then, but I'm not. A thought occurred to me about a case that I recently had, which was a young girl, 16, who was pregnant and ended up going to the Court of Protection. It was specifically that she was deemed to have, well, there was a lot of fluctuating discussion around whether she had capacity or not, but she was deemed mostly to have capacity. But in relation to the specific medical treatment that she needed, they deemed that she didn't have capacity. So I was just thinking about it, really, about reviewing it on a constant basis, but like you said before, about those specific decision-based assessments to determine whether they've got that capacity or not. Hers was that she had a lot of anxiety. She was pregnant and they needed to deliver the baby early, and yeah, she just didn't have the capacity to be able to, as you say, weigh up and make that decision. So that's why they ended up doing it. But and that was a lot of her anxiety about lots of different things. But for the rest of the time, she did have capacity. But for that specific thing, she didn't, and then that's why they had to go to the Court of Protection. So yeah,
I think I know that one. I mean, again, this kind of cases, what the Court of Protection says, please don't wait until it gets to emergency level as well. Try and make sure it's there in good time, because if it gets to emergency level, then it often is too late to do much about it, and it's difficult to get the evidence they require, and for the person to instruct people. So yeah, if it does need to go to court, try and get it there in good time. Carol, you've put in the chat, was there any record of family concerns? Yeah, there was. Family were appalled by what happened. Yeah, it was, family were devastated by what happened. I think one of the problems in this case was that it seemed to be that the GP had decided that to go down the palliative pathway fairly early on. Though this was palliative care, even though there was no evidence that the stomach gastric issues he had were life-ending or life-threatening. And because the GP had sort of used the word palliative, it seemed a lot of other agencies were sort of going down that route as well. So there's talk about, once a senior professional like a GP talks about palliative care, everybody else sees the case through that lens. But there's no saying he starved to death. It wasn't his gastric problems that were jeopardising his life. It was his refusal of care. And this was a guy with a long history of depression and anxiety as well. Any other? Thank you, Janine. You've put the link for this in the chat. Is there any other questions? Okay, no comments about this case. Again, there's lots and lots of, in the research that I talked about before, there's lots and lots of cases where in other areas people have over-relied on the assumption of capacity as a way of, of not providing services. And it's completely undefendable. You can add the reasons as to why you came to that conclusion. It's completely undefendable decision making. Okay, I'm going to shift gears a little bit. And I'm going to just change tack. So we're going to look into the mental health sphere a little bit. So a person with an emotional unstable personality disorder will generally have the capacity to make unwise decisions about their care and treatment. So let me find this. I'm going to put this out there as a polling question for you. What do people think? So as before, I'll give you about 60 seconds for this. A person with emotional stable personality disorder, or EUPD, as it's sometimes known as, will generally have capacity to make decisions about care or treatment. Just coming to the last 10 seconds. Still quite a few people need to vote for this one. Got 29 responses out of 41 at the moment. Okay, last few seconds. 5, 4, 3, 2, 1. Okay, scores on the doors. 72% of people said yep. 28% of people said false. Talk to me. What's going on for people with this question? Esther.
I just feel that any moment that you make a general decision on someone's capacity based on their condition, you've already sort of like missed the understanding of capacity, because we cannot make a general decision on a condition. So to say that generally anyone with EUPD normally makes unwise decisions, I don't think that is fair.
Or people saying that people with EUPD have capacity. You don't think that's fair either to say that?
I think anyone can have capacity or lacks capacity depending on their circumstances and at that moment. So we cannot make an assumption because of whatever condition they might have.
Okay. Okay. So good. Excellent. Section 2 of the Mental Capacity Act says that we can't make assumptions. I think it's 2(3). We can't make assumptions about somebody's capacity to make a decision based on their age, their appearance, their condition, i.e. diagnosis, or aspect of their behaviour. So just because somebody's got emotional stable personality disorder, we can't make assumptions about their capacity based on their diagnosis in terms of whether they've got capacity or don't have capacity. Anybody else want to come in there? I think I can see people putting stuff on the chat about the need to assume capacity. Again, the assumption of capacity comes in when we're actually doing the capacity assessment. The assumption of capacity shouldn't come in as a basis for not considering capacity. But section 2 of the Mental Capacity Act says we can't make assumptions about someone's capacity based on their diagnosis or behaviour. Any other thoughts on this one? There's been some research about this by somebody with lived experience. There's been a fair bit of research about this. This is somebody called Ren Aves, who is somebody who's got lived experience of mental health services. And she's done this piece of research. If you're not a patient they like, then you have capacity. That's a euphemism. What's that a euphemism for? If you're not a patient they like, what's she talking about? What's that short for? Anybody? Not unwise decisions. She's basically talking about people with personality disorders. If you're someone with a personality disorder, then you have capacity to end your life. So she did a piece of research on social media, various social media platforms. I think she got like 211 responses. Predominantly women, people with mood disorders and or personality disorders. And these are people approaching mental health services, often acutely suicidal, in severe distress, and quite often they reported that they have been told that they had capacity because they're presumed to have capacity. And when they questioned about how you came to the conclusion we had capacity, they were told you were presumed to have capacity. So they're using the presumption of capacity as a reason to not do the capacity. And time again, these people were seemingly told that you have capacity to end your life. And they were being basically fobbed off by mental health services to go and make potentially unwise decisions. And yeah, often this research was saying that people were told over the phone they had capacity, not in a face-to-face assessment. And this basic conclusion that they had capacity used to appear to roll over for time after time after time. And often, in some cases, this led to other services, such as the police or ambulance services, being contacted and told this person has capacity, they need to take responsibility for their actions, and we shouldn't be responding to them when they contact us. So someone's got their hand up. Is it Carol? Carol, you got your hand up? Is it? I can't
Yes.
see. Yeah.
Yes. I worked in psychiatry for 20 years. So unfortunately, EUPD patients, there's a lot of bias against them, for one. But we have to remember too that we're talking about two very separate pathways when it comes to mental capacity and a mental health assessment. So in a case with any patient, EUPD, major depression, whatever, is calling in, reporting suicidality, that means, well, do they have capacity? Yes. Are they making an unwise choice? Yes. However, are they at risk? Most definitely, which you would flip to the other pathway, the mental health pathway, to get an AMP, call 999, whatever out there for them. So I think we need to remember that a mental capacity assessment is not a full stop. Just because someone has capacity, what else can we do to keep this patient safe? Which is why we have the mental health pathway as well.
Mm-hmm. Yeah, but I think people aren't even getting to the mental health pathway. The mental health pathway has been denied them in these circumstances because they've been told they've got capacity. And that's almost withholding mental health care on the basis that they've got capacity, they can make an unwise choice, you need to take responsibility for your behaviour or your actions, off you go and look after yourself. That seemed to be the common theme. Now again, there's a separate question about whether someone's got capacity in terms of refusing services and treatment if they're acutely mentally distressed. That's a whole different ballgame. So that wasn't even been assessed at all. People were actually using, so again, when people try to challenge this and say, well, you've not assessed my capacity, so how can you say I've got capacity? They were being told, well, you're presumed to have capacity. So the use of the presumption of capacity is actually a way of withholding capacity assessments. Tricia.
Yeah, I think this is quite an emotive subject, especially within Stockport with current practice as well as previous. We get this time and time again, and it's sometimes really quite difficult in relation to how to navigate. But I think some of the miscommunications as well as misunderstandings of the MCA, and I think we sometimes will struggle with I suppose paramedics more than, and I think we've had examples where when you have that professional discussion in relation to, okay, so this is your capacity assessment, how did you arrive to that decision, do you know, and then trying to figure out that they can actually convey, do you know, under MCA, and they're sometimes quite maybe reluctant to do that. So you would say, can you speak to the shift on lead, do you know, to gather some, I suppose, information from them, see where they come from. But we have had examples where we've had to ring the police because there was a danger of life and limb, and people have subsequently ended up in intensive care. Police, ideally, they're actually quite good in terms of having that discussion and maybe taking some direction, and they have entered PACE under Section 17 on various occasions, and luckily each one of them, the service users, patients that we're referring to, they've survived, but it's been avoidable, really, in all honesty, and it's really quite difficult as well to try to, I suppose, see the person as the individual and the needs that they're presenting. And sometimes as well, people are sometimes a little bit reluctant to speak if people have had an overdose, and trying to state to them, but they might not be medically fit. So we can't assume as well that they've got capacity. But then if you're saying that they do have capacity, can we speak a little bit more about how you've got to that decision? So I think sometimes it could be quite a difficult sort of scenario to navigate. But we come across this, I'd say, every week.
Yeah,
at least.
It's an issue there. I mean, I think there's a couple of separate issues. So, I mean, we're talking about sort of the whole issue of capacity and suicide. And we're also talking about different agencies, about how much training they've had on the issue of capacity, especially paramedics. I did one of these sessions last year, and there was somebody there, trainer on the call from MWAS. And they were basically saying that if a person's, they're trained, that if a person's orientated to what day of the week it is and where they are, then they've got capacity. And yeah, complete nonsense. So for a person who's self-harmed to have capacity, they need to have an awareness that they've self-harmed. They need to have an awareness that one option is to go to hospital to have care and treatment. And if you don't go to hospital, then, especially if you're taking an overdose, they could suffer organ failure and die a slow, agonising death. That's the relevant information. It's not whether the person understands what day of the week it is, who the Prime Minister is, and where they are, which is generally the test for capacity assessment, for capacity that a lot of people use. But yeah, all I'm saying is that sort of there seems to be a lot of emerging evidence, mainly from the Mental Health Service, that people. I mean, I think the whole diagnosis of EUPD is, I think in 10 years' time, we'll talk a lot more about trauma. There'll be some replacement diagnosis based on trauma for people with EUPD. But we're saying to people who've experienced significant trauma in their life that we don't want you. You've got capacity, and go away and leave us alone. And that's often based because staff dealing with people with emotional disabled personality disorder, they're very busy, they don't have the time, and quite often they don't have the training or skills to work with people with personality disorder, or there's no beds in hospital to meet their needs. But rather than having honest conversations with them, they're hiding behind the Mental Capacity Act and the assumption of capacity. If anyone is interested, I'll put this here, I can send this out. I don't think it's, I think it's behind a paywall, this. It's about the issue of mental capacity and suicide. It's written by a liaison psychiatrist, a couple of liaison psychiatrists, and the barrister, Alex Rook-Keane. I will send this out with the notes from this session so people can have a look at this. But it's a difficult issue in terms of capacity and suicide. The Supreme Court said in a case called Rabone that where somebody is acutely mentally distressed, psychiatrically distressed, there's a high likelihood that they're not going to be able to weigh up the pros and cons of treatment. But there have been cases where the courts have decided that people who've taken overdoses, people who try to end their lives, do have capacity and have been allowed to refuse treatment. So it's quite a nuanced area, and we can't just come out with yes or no's for this, or true or falses. But I'll send this, I'll copy this in with the handouts. Okay, whilst we're on, sorry, this issue. One final place I want to go with this. So it's not a true or false this. A couple of people have done this question before on the DOLS refresher training. So I'm talking Sue, I know you've done this before, and maybe a few other people. But if you've not been on one of my DOLS refresher training sessions, what's the one mental health condition where the courts have found an absolute presumption that a person will lack capacity to make treatment decisions? Any takers for this? There's one type of mental health condition.
Brain damage.
Say again, someone shouted, so I didn't hear that, sorry.
Yeah, brain damage.
Not brain damage. There's not an absolute presumption. People with brain damage can be found to have capacity. What's any others?
What delirium?
Say Elise. Say again, Elise.
Would it be delirium?
Not delirium. People with delirium can have capacity. People with schizophrenia are quite often found to have capacity to make treatment decisions. There's one type of condition that every time it goes to the court of protection, almost without fail, they're found to lack capacity to make treatment decisions.
Dementia?
Not dementia. People with dementia can quite often have capacity. Keep going.
Somebody with a vertigo. Oh, sorry, I can't call the word. Somebody in a coma.
Okay, yeah, it's not. I wouldn't say that's a mental health condition, but yeah, somebody in a coma or minimally conscious state clearly can't have capacity. It's not a trick question, Alex. There's a type of fairly prominent mental health condition where almost without fail, the courts will find that people will lack capacity. Keep going. Suicide, no, people with suicide, as you just said, Samantha, people with suicidal, in some cases, it is possible for somebody to decide that their life's crap, they've had a terrible life, they've got all the pros and cons about different options, about therapy and medication, they don't work for them, and they want to end their life. Keep going.
Korsakoffs.
Korsakoffs, yeah, people with Korsakoffs can have capacity. Substances, definitely people with substances can have capacity. Hopefully bipolar people can have capacity. Keep going. I'll give you another 30 seconds. I'll give you the answer for this one.
Whether they think there's somebody else.
Say again, Elise.
Is there a condition where they think there's somebody else? So
Dissociative disorder. No, people with I'm not aware of that many cases with people with dissociative disorder, but yeah, there's a type of fairly common severe mental health condition. Sadia?
I was just going to say that is there an option, say none?
No, there's one side. Okay.
There has to be, okay, one.
I'm going to give you the answer. I'll show you.
Anorexia.
Not Alzheimer's. People with severe anorexia, almost without fail. When it goes to court protection, in terms of whether the person has capacity or not, the courts have found that, yeah, person generally is unable to weigh up and use the information to make decisions about treatment. To some degree, yeah, quite often, it's quite often women from fairly middle-class professional backgrounds who sort of educated, been to university, and they're able to sort of demonstrate clear understanding and clear ability to retain the information. But what the courts have said almost without fail, and this is a fairly famous case of RIA, is because of the overwhelming influence of the eating disorder, even though that person sort of might be 4 stone, they still believe they're overweight and they still need to continue losing weight. And that overpowering sort of compulsion to continue to avoid calories and to continue to lose weight is a trump card that completely takes over people's decisions. So when we talk about the assumption of capacity, even when these cases go to court, the courts start with the assumption of capacity and they hear expert medical evidence. But almost without fail, the courts have come to the conclusion that people with severe anorexia will lack capacity. So if you want to read more about this, there's an article by Beverly Clough that I've put there as well. So yeah, we've got 12 minutes left, coming up on time, but just wanted to summarise from today. So please, if you don't take anything else out of this session, don't say person appears to have capacity or no reason to doubt capacity without explaining a little bit more. Just a paragraph, a case note, explaining that the person's aware of what the concerns may be, what the options are, and the reasonably foreseeable risks. If you do that, because in the vast majority of cases you come across, the person will have capacity to make care choices, but that's defendable decision making. But where there's a reason to doubt capacity, we go on and we do a formal assessment of capacity. And this is where we're bringing in the assumption of capacity. When we're doing this, when we're seeing whether the person can understand, retain, weigh and communicate, is there sufficient evidence to disprove the assumption of capacity? And if we're really not sure and the risks are high, this is where we might need to refer on and consider certainly a conversation with legal about a possible application to court protection. And in life and death type situations, these can get before High Court judges within a few hours. Emma?
I just had an extra question that occurred to me when you was asking about that last point there, and it was about people with religious views. So, for example, a Jehovah's Witness that would refuse a life-saving blood transfusion or some kind of treatment, and where that sort of fitted with that, really.
Yeah, I mean, you wouldn't lack capacity because of a religious belief, because it's not an impairment of mind.
No.
Yeah.
But then,
the courts have fully upheld the views of Jehovah's Witnesses to refuse blood products, and I think quite often these are the cases where that someone might have done an advanced decision to refuse treatment 20 years ago, who was a Jehovah's Witness, and there's been a couple of cases where it's gone to court to see whether that's still a valid advanced decision, whereas the person done anything subsequently to override that decision. But the courts have certainly upheld the validity of Jehovah's Witnesses' wishes to withhold or to refuse blood products.
But it just go back to the unwise decision factor, then, wouldn't it? That even if it was a life-threatening. Yeah.
Clearly, most Jehovah's, I mean, there's probably a few million people worldwide. There's a few 100,000 people in this country who are Jehovah's Witnesses, and they have the right to refuse blood products. If they decide to do so when they had capacity, even if they haven't got an advanced decision, and even if they lack capacity and you decided what's in their best interests, the fact that they're Jehovah's Witnesses and the fact that they conform to the values and beliefs of Jehovah's Witnesses, even if they lack capacity, it's very, very unlikely to be in their best interest to give them blood products, even if there's no advanced decision to refuse treatment.
Yeah, because that was kind of a similar thing with the young girl that I was the IRO for. Obviously, outside of that particularly stressful and traumatic experience, perhaps she would have had the opportunity, but when it was all happening and she didn't have that time, and obviously it was determined that she didn't. So in the moment, I guess I'm just exploring how that impacts people's capacity more generally. And my background's not adults, so obviously I'm from children, so it's not something that I come across every day. But yeah, no, thank you.
Well, this does affect, so children 16 and 17, this applies to everything we talk about.
Yeah.
There's an overlap for 16 and 17-year-olds where you could consider both GILIC and also capacity. But what the courts have said, if the young person who's 16, 17, if they've got some kind of impairment of mind, learning disability, autism, mental health issue, then we should be using the Mental Capacity Act tests because it gives more safeguards than GILIC. Yeah.
And I think you're right in what you said before about, well, somebody else brought it up about the impact of trauma and adverse childhood experiences on, it's not a diagnosis, but it's an impairment of the mind, and that's why I was particularly interested in that. Thank you.
And a lot of people who have that trauma as young people go on to develop or get diagnosed with emotional unstable personality disorder, which is just another for somebody who's experienced chronic trauma and abuse.
Yeah.
So I think the other takeaway message would be just be very careful about making any kind of judgment about someone's capacity based on their diagnosis or their symptoms at all. Just because the fact that somebody's delusional, the fact that someone's hearing voices, doesn't mean they lack capacity. It's all about their ability to understand, retain and weigh the relevant information that they need for that decision. Unless somebody's got a very severe eating disorder. I think we talk about severe eating disorders generally where their body mass index is under 14. Any other questions or comments or anything anybody wants to bring in? I need to keep hold of you for 2 more minutes. I need a quick evaluation of you. So it's the quickest evaluation you'll ever do this. It'll take you 2 minutes. So for those of you who don't mind using QR codes, you can scan that on screen. Alternatively, if you go to, I'll tell you what I'll do. I will just, I'll put a link in the chat to make it a lot easier for you. Right, give us a second. I'll put the link directly in the chat. If you click on that, you should be able to get to the evaluation. Oops. Yeah, so the link is in the chat. So if people could literally spend 2 minutes doing a quick evaluation. I'm not on the clock today, so if anyone's got any questions and they want to speak off record, I'm happy to knock around for a few minutes afterwards as well. But once you've done your evaluation, then yeah, you're free to leave. In fact, what I'll do, I'll see if I can put that article. I don't know if I can do that actually. No, I'll send the article about suicide incapacity. I'll send that on with the slides afterwards. But yeah, thank you very much. Thank you to everyone for participation today as well.
I've said